Got it. Good afternoon, everyone. My name is Liz Murphy, and I'm the Assistant Director for Communicable Disease and Epidemiology with DuPage County Health Department. So excited for you all to join us for what promises to be an excellent conversation with Dr. Susan Davis about transitions of care and discharge and antimicrobial stewardship. Dr. Susan Davis is a clinical professor and interim associate dean for pharmacy at Wayne State University in Detroit, Michigan. Since 2005, she has also maintained a clinical appointment as an infectious diseases pharmacy specialist at Henry Ford Health System. She is a graduate of the University of Michigan, completed her residency training at Detroit Receiving Hospital, and a fellowship in infectious diseases outcomes research at Wayne State University. Dr. Davis has published over 90 peer-reviewed manuscripts and is the program director for the ID Pharmacotherapy Fellowship at HFH and WSU. Her awards for practice, teaching, and research include the American Society of Health System Pharmacists New Preceptor of the Year, the SIDP Clinician of the Year, and the Wayne State University College of Pharmacy and Health Sciences Research Excellence Award. She is the current president of the Society of Infectious Diseases Pharmacists and recently served on the National Institutes of Health COVID-19 Treatment Guideline Panel. When not in meetings, she enjoys training pharmacy fellows, residents, and students in antimicrobial stewardship and practice-based research. So with that, welcome, Dr. Davis. If you have any comments or questions, please leave them in the chat, and we'll get to those at the end of the presentation. With that, take it away.
Thanks for that introduction, Liz. I really appreciate it. And thank everybody for attending. I think you guys have had a long day of really fantastic content. I've been trying to check in on things myself. So if I'm doing this right, I need to stop sharing my video and start sharing my screen. As I heard Liz say earlier, please share comments in the chat. I won't be able to see that as we go because by sharing my entire screen, I don't get to see the chat box. There are several spots during this presentation that I'm going to ask you to share some comments with each other. So I hope you will be doing that, even though I'm not there to force you. And we'll come back and share some of those comments together and walk through it at the end to hopefully have some good, robust question and answer. So again, thank you for coming today. Thanks to the organizers for inviting me. I'm really excited to share our experiences with stewardship and transitions of care to give some tips and tools for how you might approach similar problems in your institution. As mentioned, and I put in the chat, slides will be available to you for this session, and there's a link in the chat where you can download a lot of the tools that we developed at Henry Ford as part of our project with the CDC. My disclosures are listed, nothing relevant for this presentation, and notably, we're not talking about any specific products or any off-label indications. My goal is for this session to be as interactive as possible given the format. There will be, as I said, some points where I'll pause and ask you to type some comments and suggestions into the chat for you to share with other attendees within your network and community. My ideas are not the only good ideas out there, so your experiences can be really helpful for others. If this were an in-person workshop, I'd be going around the room and forcing you to talk to each other directly. I would also encourage you to have a couple sheets of paper handy to take some notes during our stopping points. We'll come back at the end to reflect on the responses that you've shared. You might be attending this session for a variety of reasons, but hopefully you're already well aware of the twin problems of antibiotic resistance and harm from antimicrobial therapy that pose a significant public health threat. National estimates suggest that every 15 minutes, someone in the US dies from a drug-resistant infection. And among patients who are sent home from the hospital on antibiotics, 1 in 5 experiences an adverse drug event. Some of these events are preventable by reducing excessive antibiotic therapy. In minimizing that harm, we know that every day matters. And sometimes that sounds a little silly, of reducing a duration of therapy from 7 to 6 days or 10 to 8 days. but reducing unnecessary therapy by even a single day can reduce a patient's risk for harm. It's estimated that there's a 9% increased risk of C. difficile for every day of antibiotics in patients with pneumonia. For patients receiving anti-pseudomonal beta-lactams, the risk of drug-resistant Pseudomonas increases 4% for each day of therapy. And for every 10 days of antibiotics, there's a 13% increased risk of serious adverse drug events. So every day is a new risk-benefit calculation and an opportunity to recommend the minimum effective duration. Recently, the Pew Charitable Trust partnered with the CDC and other public health and medical experts to evaluate antibiotic use in hospitals, as well as to set some national targets to improve prescribing. These findings were shared in JAMA Open Network in a paper a few months ago with one of our previous speakers, Melinda Newhouser, as an author. Using national prescribing data, this team examined the use of two important antibiotics, vancomycin and fluoroquinolones, as well as antibiotic treatments for community-acquired pneumonia and UTIs. The key findings from that analysis showed there is considerable room for improvement. They found 79% of all antibiotic prescriptions for CAP and 77% of those for UTIs had some element of inappropriateness. The panel recommended a national target to reduce that inappropriate use by 90%. 47% of all fluoroquinolones and 27% of all vancomycin prescriptions were also found to have an inappropriate element. The panel recommended reducing that inappropriate use by 95%. So when we think about these targets and this overuse, it probably hits home that that's something we're seeing about every day. And strategies for reducing that inappropriate use are something that we might need some help with. Well, one place we know some of these antibiotics gets overused is at the time of hospital discharge. And it's really easy to understand why. Patients in the hospital are started on an antibiotic, usually IV therapy. They may have changes in drug selection, dose, route. And when it comes time to write a discharge prescription, it's really easy to think in those traditional durations of therapy, like 7, 10, and 14 days. But that doesn't account for the therapy already received in the hospital. Because of improved awareness of this problem, improving discharge stewardship is now one of the suggested actions in the CDC's updated core elements. So now is where I have one of those exercises for you to do at home, either on your note paper, and please feel free to share your comments with each other. Before I advance to the next slide, take a piece of paper and write down your answer to this question. What % of discharge antibiotic orders do you think are optimal at your practice site? Meaning they're not only the right drug and dose, but also the right duration. So I'm hoping you're sharing some guesses there. Maybe you already have this information. Maybe you're taking a good guess at it. One of the things I would ask you to think about in determining whether you can make some improvements in discharge antibiotics is, have you evaluated this data? So as you share your suggestions, if you don't have this information now, how might you get it? I think you'd need a guideline document for what the right duration is, a way to combine inpatient and discharge antibiotics into the total duration, and probably some selected indications that you want to focus on, like pneumonia and UTIs. This seems like a great project for trainees if you're lucky enough to have them. So a number of years ago at my practice site, we assumed this was a problem, but we also documented that it was a problem. We completed a very small observational study of quinolones used at the time of discharge and found that 54% were given for an excessive duration. Regionally, in a statewide collaborative, 68% of pneumonia patients were found to have excess duration, and the vast majority of that excess therapy was given after hospital discharge. That Michigan Hospital Medicine Safety Consortium has since found similar results for other infection types. So we know this is a very real problem. You can find more of their data at their website, michiganhms.org, and search for the Antimicrobial Use Initiative. So that leads us to the implementation of an antimicrobial stewardship transition of care model at my health system. This work was completed as part of a contracted project with the CDC. It's previously been shared at SHEA, and final publication is finally back on the front burner as our team recovers from the pandemic. The tools and documents I'm sharing with you are available on Henry Ford's Antimicrobial Stewardship Transitions of Care website that I linked to in the chat. The objectives of this project were to implement a new standard of care for transition of care for patients discharged on oral antibiotics, to improve antibiotic selection and duration of therapy, and to reduce the burden of antibiotic-related harms and resistance in our community. Before sharing the results, I'm going to go through all of the nuts and bolts of our implementation, hoping that you can find some parallels to processes at your own health system. The setting for this project is Henry Ford Health System at 5 integrated hospitals across Southeast Michigan. The flagship is in downtown Detroit that has a traditional academic model. The hospitals and community locations have varying practice models. However, notably, each site has a local physician champion for stewardship and a pharmacy leader between half and 1 FTE. This project was rolled out as a stepped wedge across those participating hospitals, mostly for the purposes of feasibility. It was implemented first in general medicine units at the academic center. In the second step, it was implemented in academic specialty units and a progressive care unit at one of our community hospitals. And then in the third step, it was implemented in the mixed units at the remaining 3 hospitals. The population for intervention included adults on inpatient wards with urinary, respiratory, skin, or intra-abdominal infections, and the outcome of interest was optimal prescribing at discharge. The key place to start the conversation about implementing antibiotic stewardship at discharge is understanding the transition of care process for medications in general. Traditionally, these steps are identifying patients prior to discharge, assessing drug therapy, assessing readiness for discharge, and then placing appropriate discharge orders. Pharmacists, nurses, and physicians are likely already working on this process for chronic medications at discharge at most of your practice sites. So my next exercise for you is to think about those steps. What is the current workflow in your institution for patient identification, assessing drug therapy, assessing discharge readiness, and facilitating discharge orders? Who are the people currently involved in those steps? Is it nurses? Is it physicians? Is it pharmacists? Is it a combination of all of those? What about case managers? And so if you think about that for non-antibiotics, the next question that maybe we'll get to soon is, could antibiotic optimization be included in that discharge MedRec process? For a lot of people, the immediate reaction to that is no, but I'm hopeful that you're here listening and learning to find ways to make that work. So in my health system, we leverage things that were already being used by case managers in the electronic medical record to help with early identification of patients preparing for discharge. I'll show you some of those tools in a minute. For assessing drug therapy, we used our antimicrobial stewardship pharmacists to train the unit-based pharmacists who are on the primary teams to assess the combination of total and appropriate duration of therapy according to our institutional guidelines. So we did have local guidelines already in place, not just for appropriate drug selection and dose, but also recommended duration. We used existing communication strategies, including collaborative and teaching rounds, depending on the site, to communicate recommendations from pharmacists to the primary teams. Often those were led by nurses on the collaborative rounding units. To ensure follow-up, pharmacists pre-prepared discharge prescriptions and queued them up to include the appropriate stop date and documented a note to communicate the rationale for that duration in the electronic medical record. Because our health system has some heterogeneity, each of those steps was customized for both academic and community models. The participating pharmacists included both the stewardship pharmacists as well as clinical pharmacy generalists, depending on the team. Patient identification strategies were customized by the local practice, as were the communication strategies. So the next set of slides includes examples from tools that we used in implementing the intervention. These here were some of the important steps for ensuring success of the program. Getting good stakeholder discussion and buy-in, developing a clean and understandable workflow for the pharmacists who were doing this implementation, making sure our pharmacists were aware of the existing institutional guidelines and had adequate support to interpret them, an educational overview for nurses and physicians on each of the participating units to make sure they understand their role, the need for the problem to be solved, and how the pharmacist would be helping them. Lots of electronic templates for documentation to make things easier, plus metrics for success that we could communicate as the implementation rolled out. So for a stakeholder discussion, we used a discussion guide that was consistent for each practice site to encourage conversation with the stewardship team and those local stakeholders prior to project implementation at each site. This included pharmacy directors, stewardship leaders from physician and pharmacy staff, outpatient pharmacy managers, nurse managers, and unit directors. For each of these things, we discussed the project goals, the process, and customization options that would help them meet their individual goals for quality improvement on their units. A pharmacy workflow guide was created on a pocket card to help train the pharmacist in the process and make sure they could find all the documentation and tools that they needed to implement things. So this was developed with feedback from the frontline pharmacists, and updates were shared by those leading pharmacists on an ongoing basis using a frequently asked questions forum. There were a number of pharmacy-specific strategies for electronic medical record optimization related to identification, prescription preparation, communication handoffs, and note templates. That's getting in the weeds a little, but if you want to try that yourself and see the examples, screenshots are available in the slides. One of the important steps in the process was making sure everyone was on the same page with what discharge readiness means. But not just what it means for any patient, but in the context of antimicrobial therapy. So this includes clinical stability, plus the ability to take and access oral medications. If barriers to medication access were known, pharmacists would work ahead to obtain approvals or recommend alternatives. This also included communication with outpatient pharmacists on the receiving end of those discharge prescriptions. It was pretty vital that the teams were consistent with recommendations for duration of therapy. So this was the other side of that workflow pocket card that we made available to all of the participating pharmacists. We consolidated the recommendations from all of the individual institutional guidelines into one single easy reference and included a refresher on the criteria for short course therapy in our educational materials. Each participating unit had an informational meeting for the leading pharmacists to review the rationale, the process, and goals 1 month before implementation. These conversations included all of the participating physicians, as well as the trainees when those were teaching services, the nurses, and the case managers. We established in advance the goals for process measures to be able to communicate our process. This included a total number of patients served each month and an aggregate, as well as the proportion of eligible patients who were reached. These numbers were shared publicly on a monthly basis and used to identify barriers and opportunities. And because we're pharmacists and do like to get in the weeds, I've got some screenshots here for you of that EMR optimization. So we added the expected discharge date column in the electronic medical record. Our example is in Epic.
Dr. Davis, are you still there? Yeah, Dr. Davis, you're muted. Are you able to unmute yourself?
Okay, it's doing
I
that
can
thing
hear
where it
you
mutes itself.
now. I can
Okay.
hear you now. So,
So this is doing the thing that it was doing earlier. Please let me know if it leaves again. And so when did you stop hearing me?
if you can go back to sharing, probably earlier in this slide before some of the additional pop-ups were coming up. Yeah.
Okay, perfect. So we noticed in training on this, the microphone tends to turn itself off in the middle. So my friend Melinda, thank you so much for letting me know. Really appreciate you. Okay, so just backing up briefly, it looks like you heard this one. We'll go on to the next slide. That this is where I think our practice gets to the slightly more progressive than what we've seen that's been implemented elsewhere. And that's where we gave our pharmacists delegated authority to pre-enter the discharge reconciliation antibiotic prescription. They were instructed to include the appropriate count of days as well as the dispense amount. So instead of giving a nudge or a call or a gentle suggestion, our pharmacist recommendations were, here's the suggestion, and I'm putting the order in the right way so it's there when you discharge this patient. Takes it a step further, puts a little bit more responsibility on that pharmacist, but it also helps ensure that things happen smoothly with the correct end date. So, in case discharge did not proceed exactly as planned, the pharmacist also included in the notes to pharmacy section of that discharge prescription the exact end date and indication. This would go to pharmacists on the receiving end, both within our health system and external. Our affiliated outpatient pharmacists were included in the entire process and received the education to know to look for this end date. They also then would be able to modify the dispense about to match if there was an error. Not able to do that in external pharmacies, but knowing our discharge prescription processes, the vast majority did go within the health system. The hospitals were already using iVents within the electronic medical record for pharmacy communication and handoff. So our IT pharmacists created a subgroup of iVent specific for stewardship transition of care. This became really useful if, say, on a Friday, a pharmacist was anticipating discharge might happen soon, but they hadn't quite come to a consensus of exactly what to do. So this allowed our weekend stewardship coverage to catch these for follow-up. We don't routinely have weekend stewardship at every single hospital, but our trainees do that at the downtown academic center. During the project itself, pharmacists led multidisciplinary feedback sessions very frequently. An FAQs document was shared among the staff, and we talked about missed opportunities as well as success stories among the participants. And we brought the trainees into those because they were also not just our residents, but also our students doing a lot of this follow-up and education at discharge. So objective one, if I can refresh you, was to implement a new standard for transitions of care for patients discharged on oral antibiotics. I would say that was successful. Over the course of 10 months for the project itself, we optimized the discharge prescriptions of over 1,500 patients. Among the randomly selected eligible patients, protocol adherence rate ranged from lows of around 30% to highs of about 85%. Months of low protocol adherence were associated with times of reduced staffing or when we were onboarding a large group of new employees or trainees. By reviewing those metrics routinely, we were able to implement improvements in real time. Coverage over the weekends was one of the biggest challenges at some sites, as was communicating with offsite prescribers. So we were able to institute improvements while we were doing this implementation process to reach those prescribers. One common area needing clarification was literally how to count days of therapy to determine an appropriate stop date. So we created a guideline of how to count days and shared multiple examples of the times that it can get confusing. We also had some surprising successes, like the number of patients who didn't need discharge stewardship interventions because they could stop therapy while inpatient. So those were always a fun win. Objective 2 was to improve antibiotic selection and duration of therapy prescribed at discharge. So to evaluate that, we included 400 patients before and after the intervention. Their demographic characteristics are included here. Based on the stepped wedge, we had more patients in the pre-group from community hospitals. That's also reflected in the payer mix. A history of an ICU stay was rare based on the nature of the participating units. About half of the patients in each group had respiratory infections, either pneumonia or COPD exacerbation. The next most common indication was urinary tract infections. Other comorbid conditions were relatively common, as were recent antibiotics or previous hospital admissions. But here's the major headline. This is my favorite thing to get to talk about. Prior to the intervention, 36% of discharge antibiotics were optimal, meaning the correct drug, dose, and duration. If you go back to the guesses I asked you to take at the beginning of this presentation, what did you think your percentages were going to be? Is it higher or lower than this? Well, ours was 36%. With the intervention, that increased to over 80% optimal antibiotics at the time of discharge. We're really proud of that. Secondary outcomes are reported here. As expected, there were no changes in clinical resolution at discharge or follow-up. These patients should have been resolving to be eligible for the intervention in the first place. Nor was readmission impacted. However, the intervention was associated with a reduction in adverse drug events and subsequent identification of multi-drug resistant organisms. That's consistent with the project's third objective to reduce the burden of antibiotic-related harms and resistance in the community. The nature of those adverse effects is listed here, and after adjusting for infection type and comorbid condition, including non-ambulatory status, the receipt of optimal antibiotic therapy was associated with a significant reduction in risk of adverse drug events. You might be skeptical, again, that by reducing a day or two of excess antibiotics per patient that it would matter to this degree, but think back to where we started. Every day matters. Every day of unnecessary antibiotics, every day of any antibiotic increases risk of harm. We found the same here. We found the same to be true, that in reducing that excess therapy, we reduced harm. I will say our model is not the only model that can work. There are a couple examples from the literature pointed out here. The stewardship team at Summa Health System in Akron implemented a discharge stewardship intervention. Their tools included a worksheet for the stewardship pharmacist, use of national guidelines, and recommendations communicated to prescribers. In a small comparison that was published in Itchy, this improved appropriate prescribing on a similar scale, honestly, to what we observed. And at Michigan Medicine, down the road a bit from me, they've piloted a pharmacist-led antibiotic timeout at discharge from a hospital medicine ward, finding that 18% of timeouts result in a change in therapy. And their surveys report high satisfaction and feasibility of the intervention. So here's another time when I'd ask you to reflect back on those discharge therapy steps. If you reflect on this at home, go back to thinking about who's involved in those different steps. And the examples of our tools and our interventions that I showed you, are there things that look like they might be feasible? And where in the process do you see opportunities for antibiotics to be included in your discharge medication process? I'm going to take a minute here and be quiet because I really want you to share right now in the chat, is there a place in discharge medications that you think you have an opportunity to improve antibiotics at discharge? And I can't see this, so I'm just going to sit here, cross my fingers. Okay, keep on sharing because I want to come back and read it and reflect on it and talk about it when we're done. So before we jump to the end and questions and your thoughts, I also want to share with you some of our insights on discharges with intravenous antibiotics. The challenges with antibiotics at hospital discharge are very much the same here. Plus, we have the added complications of identifying patients that have the appropriate support to be candidates for IV therapy after discharge. This includes things like placement and training for IV access devices and coordinating with payers and the facilities who are providing that post-discharge IV therapy services and monitoring. So outpatient parenteral antimicrobial therapy is a very helpful option for certain patients who require IV antibiotics but no longer need hospitalization. There have been multiple studies demonstrating improvements in safety, in resource utilization, and in patient satisfaction. Also, lots of these programs report cost savings to the health system. But setting up the process for OPAT takes some considerations across the continuum of a hospital stay. This graphic shows some of the best practices that our hospital has implemented to reduce unnecessary OPAT in patients who would qualify for oral therapy, as well as to improve discharge processes. Our physician consultation policy requires an ID consult prior to placement of vascular access to avoid unnecessary PICC lines. Once placed, the inpatient pharmacist on the primary team embedded at the unit level provides OPAT medication education. We also communicate with case management as soon as those outpatient IV prescriptions are placed to assist with discharge referrals and payer coverage. The prior authorization process here can add days to a hospital stay, particularly for high-cost antimicrobials. So not all is well in the world of OPAT and discharge transitions. In 2017, a survey of the American Medical Association identified that 92% of physicians find prior auths result in care delays, and 78% suggest that some of these lead to abandoning preferred therapy. Now, this survey was not specific to infectious diseases, but it did include antimicrobials, and it reflects a lot of the experience that I think my colleagues frequently discuss. So a couple years ago, we challenged one of our PGY2 infectious disease residents. This was Monica Bianchini. She's now completing her PhD at Colorado. Watch out for her in the future. And we asked her to quantify how much those discharge delays associated with OPAT were costing the hospital. Her study was limited to the top 5 high-cost IV discharge antimicrobials at the time, so daptomycin, ertapenem, ceftaroline, and cephalosporin beta-lactamase inhibitor combinations. And she quantified both prior auth delays and discharge delays. In general, Dr. Bianchini found that 30% of patients prescribed OPAT for these agents had a discharge delay, and 26% had further delays. So 30% with a PA delay, 26% had a delay in their anticipated discharge date. And this makes sense. I think we look at all of the potential problems in the process. Patients are stuck in the hospital longer. After controlling for other factors, the single most common predictor of a discharge delay was a planned discharge to a facility as opposed to home or in-clinic infusion. Again, this also makes sense. The daily cost of some of these antibiotics can be more than the daily reimbursement for a post-discharge facility's care. You can't take a patient whose single antibiotic costs more than you're receiving in reimbursement. So this is a huge challenge in placing patients who maybe aren't quite ready to go home. So when taken to the next logical step, we identified that patients with those prior auth delays had a discharge delay on average of 5 excess days. Factoring in the relative costs, that's about $4,800 in hospital costs per patient. This is enough to grab the attention of administrators in the health system and say, hey, we probably need some help with this. So since then, our health system has made a number of additional improvements in the process. ID consultation had often been delayed until just before PICC lines were being placed, but we now recommend that as soon as OPAT is being discussed as a likely option. We also have worked closely with case managers, absolutely vital partners, to identify patients who have risks for delays. Those risks that we found are those with only public insurance or discharge planned to a facility. And that helps us start the prior auth process early. We've also helped clarify some EMR documentation to help support justification for OPAT with these antimicrobials and encourage involving the patients themselves very clearly in discussion of the benefits, costs, and expectations. So if IV antibiotics are one of your stewardship priorities, I would ask you to think about how you identify these patients and what kind of workflow do you have to facilitate those discharges. Just like we go through the steps for optimizing oral antibiotic therapy discharge, this is a little bit more complex, but you can find some opportunities. Maybe you consider having financial navigators assist. And worst case scenario, maybe there are alternative ways to get these patients the medications they need. Best case scenario, if oral options are available, optimizing with oral therapy is a great alternative. So starting to wrap up and hoping to have some more Q&A discussion and feedback, I do have one question, short question here for you to think about, and that's, which is a bigger discharge antibiotic problem in your practice? Is it oral antibiotics or IV antibiotics? Please share that in the chat, as well as why that is a bigger priority for you. So maybe oral antibiotics are a bigger problem because there are more of them. Maybe IV antibiotics feel like a bigger problem because they're more expensive and more complicated. Depending on your perspective, you might want to tackle one versus another of these if you're trying to fix your discharge antibiotics. I also think working with long-term care facilities, working with home infusion, if that's your perspective, obviously the IV antibiotics end up being a big deal. So I'm happy that maybe a few of you will be able to share some of your insights in the chat about those experiences. So now I'm leading into a summary exercise that I want you to take home with you. Hopefully this is able to make you walk away with some action items. Coming back to that overall process of integrating antibiotic stewardship for discharge medication practices. For each of these steps, what do you have currently available in terms of structure, in terms of personnel, and what other resources do you need to improve antibiotics at discharge? So in patient identification, in assessing appropriate antibiotics, in having local duration of therapy guidelines, in communicating recommendations for discharge duration, and who facilitates optimal discharge prescriptions. Put into a table, this would be something I would encourage you to sit down and brainstorm. Use this as a discussion guide for your stewardship teams at home if you want to tackle discharge medication transition of care. Finally, before we come back to Q&A and reflect on some of your responses, I'd remind you the tools that I've shared are available for you to access through Henry Ford's website. This includes the program overview, the gap analysis tool, discussion guideline for stakeholders, and a lot of other useful examples. Also, as Dr. Newhauser shared with us earlier today, there's a brand new roadmap from the CDC that can provide some additional inspiration for developing your process. So I'm going to stop sharing my slides. I'm going to come back to showing my screen. And first, we're going to go through each of those questions that I had asked you. I'm going to flip through what you've entered in the chat. If you didn't have a chance to respond then, we'll do it now and reflect back and forth a little bit. And then I also have some questions for you in addition to this, if you don't have more questions for me. So hopefully we get a little bit of interaction at this point. Okay, so let's see how well people are following instructions. Oh, come on, I didn't see a lot of responses here. Okay, first question, people, was what percent of your discharge antibiotics in your hospital do you think are optimal? Please share that in the chat right now. So I told you ours was 36%. Maybe you think you're better. Maybe you think you've got some good work done on that. So please share your thoughts of where you think you are to begin with. And if your answer is I have no idea, I haven't looked, that's also useful. That's fine to share too.
And Dr. Davis, one interesting comment related to that from Emily Jolly, that the percentage varies greatly by prescriber in some instances. So wondering if you have any thoughts on that, or if you've seen that in your experience as well.
Absolutely. I think a lot of us would say that discharge prescription optimization is going to vary by prescriber. So all antibiotic prescribing seems to vary somewhat by prescriber. If that's how you want to tackle things on more of a individualized dashboard, individualized feedback, I think that depends a little bit on your stewardship model. Are you a one-to-one kind of communication and facilitation? Do you like to do some of that public peer pressure? Is that useful? I tend to think that that's a little bit labor intensive for something like this. We certainly were able to show on a unit basis or a group basis, but going to the individual prescriber level, we chose not to do that, in part because you can only do so many things at once. But I would absolutely agree that that there's a lot of variety by prescriber. So looking at people's suggestions in here,
Really quite the range. I'm seeing
quite a range.
25%, 75%, 60%. So yes,
Yep.
all over the place. Lots of room for improvement.
Lots of room for improvement. I mean, 75%, I would be impressed if we had started there. So whoever's saying that, I bet you've already done some work in the background to try to get things optimized. So awesome. If you're doing some things related to that, please feel free to share with the group. The second question I had posed for you, and before I go back and look for other questions from you, the second question I wanted you guys to answer was who's currently involved in discharge medication processes at your health system? So is this physicians, pharmacists, nurses, someone else? Who's currently doing discharge medication process for non-antibiotics? Anybody willing to share that? Oh, I love that there's some people doing some resident projects on this now. That's good to hear. So I will tell you, prior to implementation of our process for antibiotic transitions of care, we had pharmacists doing discharge medrec on a few different indications. So just a couple chronic medications. So COPD and heart failure was where pharmacists were involved. The rest of discharge medrec was a nursing responsibility. So it could have been, if we had chosen to, a nurse intervention, but I'm a pharmacist. And I think pharmacists are well placed to have some of this antibiotic information. Our stewardship model is very pharmacist based, so that was where the natural extension was. But I think a partnership of multiple different staff makes a lot of sense. Again, thanks, Erica, for sharing that your primary team provider and nurses are doing the bulk of that work. I think that's true a lot of hospitals. And Radhika says they've got some floor medrec pharmacists and ED pharmacists doing this. I think that role of medrec pharmacist is pretty common. It's becoming increasingly common at health systems. So then the challenge I'll give you guys is if they're focusing mostly on non-antibiotics, why not include some antibiotic optimization? One of the challenges that we had with that was the discharge medrec folks would include antibiotics there, but they would just keep the same duration that the prescriber initiated. And as you were finding, 36% of those were wrong. And I think for me and for a lot of us, we see how it's frequently wrong, that a patient might be in the hospital for 2 or 3 days on antibiotics, and as you prepare for discharge, if you're not worried about doing the shortest course possible, you think, what's the indication? Pneumonia. Okay, that's a 5-day duration or a 7-day duration, depending on the patient. And that's what you would prescribe at the end, not counting those inpatient days. And when people are busy to get those discharge prescriptions processed, it takes someone clearly focusing on this to stop and make that recommendation and that edit. So excellent. I'm seeing Jamie Burkowski's got frontline pharmacists doing non-antibiotics and antibiotics. That is awesome. I am excited to see your residence project someday soon. Very cool. So the third question I asked you was, which issue is a bigger problem for you? IV antibiotics at discharge or oral antibiotics at discharge, and why? So if I circle back, I don't think many people had a chance to respond. So can you do that for me now? IV or PO, which is the bigger headache for you and why? Thank you guys for humoring me and putting these comments in. I learn a lot from what you're able to share, and gosh, I wish I were in Illinois and able to see you guys today. Maybe another time. So as I mentioned, and hopefully some of you are sharing your thoughts, it really depends on your perspective, which is the bigger problem and what you need to focus on. For us, IV antibiotics as a big cost issue is really important to a number of folks, but oral antibiotics is probably our bigger public health concern. So depending where you're sitting, one might be the first thing you want to tackle. And Sandy is sharing IV antibiotics due to timing issues. I can understand that too. That timing around discharge, getting the right IV therapy, depending on the facility, both. Local nursing homes have a max on the number of oral administrations. So I haven't run into that very often. That's a challenge. So lots of unnoticed problems in duration. So lots of role for optimizing dosing and administrations. So the last question I had for you is to think about the different steps and what resources you have versus what resources you need. So the next thing that I'm going to beg you to share with me, if you think about all of the different things, stakeholders, templates, the right people in place already doing discharge, what is the number one best resource you already have right now that you can leverage for discharge antibiotic stewardship? What's the top thing you already have that you can take advantage of? And I'm seeing some people are still responding on IV and oral, and I'm agreeing. Oral are a bigger perspective for some, IV for another. We can't do just one. Can't really have one without the other. So I think I would say, regarding that big picture, what is the most useful, most important thing we had in place at my health system in advance was the pharmacy practice model. That I'm fortunate to work in a health system where at each of our hospitals, a pharmacist is embedded at the unit level on the patient care teams everywhere. That it's a little bit thin occasionally, but there is a pharmacist assigned to every care team. And that model allows pharmacists to be present at the discharge discussion, present at collaborative rounds as those discharges are planned. That is the thing that we decided to take advantage of. That would be the place where we could house our intervention. So just depending on how your teams are deployed and who's leading this, I think Andrew's saying his TOC pharmacists are the biggest thing to take advantage of. I agree. If your pharmacists are doing TOC, even if they can't do this themselves, they can help your other pharmacists do it better. The same thing with stewardship. Your stewardship pharmacists are probably not able to take this on themselves entirely. You've got too many other fires to put out on those stewardship services and helping your consult teams. But your ID pharmacist, your stewardship pharmacist can empower all of the other pharmacists by providing guidelines, by providing support and education and advice, and occasionally a little bit of a nudge and feedback. So I think that's really, really useful. Radhika has a great comment on bedside nurses and advanced practice in stewardship efforts. I completely agree. That is another great opportunity and a great angle to try to optimize these things. So thank you guys for answering my questions. I'm going to scroll back and see what some of your questions were for me as we've gone. Okay, you're welcome for the slides and the handout stuff. Excellent. Yeah, great comments. Lots of improvements made in the ED. Kim, nurse and infection control. I think your comment here is a great highlight of follow-up calls after emergency department discharge. We did that for a while. Pharmacists were doing that for a while. The physicians took it back, and they're doing just as good now. So that was excellent. I saw a comment or a question in here asking to share the process for the data collection on the cost and extension of stay. It's been a while. I would be happy to share that format for you if you want to contact me. It would take me a few days to go back because it's been a while since we implemented that protocol. But I would be happy, Erica, if you send me an email to share some of that data collection form if you'd like to replicate something. What other questions do you guys have? I'm just going to keep commenting on the things that you've shared. Jacqueline Meshke, is it? 4 clinical pharmacists on the floors. That, I agree. That sounds like a great place to start. And helping with that communication between the pharmacist and the nurses and physicians. I think if you look back through the slides that I shared with you, one of those discussion guides got all of those people in a room to hear from the ID team, and in this case it was ID pharmacists, to say, here's the issues that we observed. We collected this data on quinolones specifically, but we shared our local data, we shared national data and regional data, and said, this is what we're proposing. Here's what your role is going to be. We're going to do most of the work for you, but helping to have that connection and then empowering the pharmacist to just do it, I think took a load off of people's minds that frequently when we're going with a new intervention to a busy patient care service, it's just one more thing we're asking for them to do. And in this case, it's, hey, just give us the information and we're going to take care of it for you. Again, if I'm not seeing a whole lot of additional questions, but I really, really appreciate the feedback and the comments that you guys have shared. We are closing in at 5 minutes before the end of the session, so I'm going to stay here if you do have additional questions. Oh, Natalie, okay. Tips for how to start when your floor pharmacists have 70 patients each. This is not that different from my hospital. So our floor pharmacists have 60 to 70 patients each. One full-time stewardship pharmacist, Rachel, not myself. I don't count myself in the model. I'm the academic nonsense person. So one full-time stewardship pharmacist, 900-bed hospital downtown. Natalie, I don't know if you have trainees, but the way we have deployed pharmacy students and residents helps to enable all of these types of pilots, that having students and residents offset some of the activities pharmacists would be doing, lets the pharmacists go carve out new services, or if it's something appropriate for a trainee to do, they can pilot. So that is, I think, one of the most important things as an educator is to make sure our trainees are embedded and embraced in our patient care models so that they're extending care and not adding burden. So that's kind of a separate issue. The other thing that I would say is, not all of our hospitals have as many trainees, and they were still just as successful in implementing. And I think the issue just became talking about priorities and what you do first, helping people triage, helping people find efficiencies in their workflow where maybe you don't need to be spending so much time on vanco dosing. So that's also a thing that we were able to give some advice on. That, as an ID pharmacist coming to talk to the floor pharmacists, one of those big things is how can we help offload the other antibiotic related work you're doing, and we waste a lot of time on vanco. So that was another thing that we were able to cut down. From Bridget, given pneumonia is a large player at discharge, do vaccines play a role in stewardship? Of course they do. And I think we've been learning even better vaccine opportunities during the pandemic of trying to capture that captive audience of inpatients to try to administer vaccines. Hopefully there will be some lessons learned from there that we can and should administer and document vaccines to hospitalized patients. I think one of the challenges, though, that we can have with that is, what is the payment structure? What's the reimbursement structure? That if we want to offer things to an inpatient, if that's competing with people who want to get those vaccine clinic appointments, that's always a weird cost and reimbursement conversation. From my perspective, if you have a patient vaccine eligible sitting in front of you, they're not actively sick with something that is a contraindication to a vaccine, that can absolutely be part of it. It's much harder to capture that proactive vaccine impact on antibiotic resistance and stewardship and make those direct connections epidemiologically. So vaccines as part of a discharge intervention is a little harder. Vaccines as a follow-up post-discharge intervention, I think we do a pretty good job with that in a lot of systems. Are there any other questions? Oh, cutting down time spent on vanco monitoring. Part of it was, there's a lot of controversy over vanco monitoring anyway, but I think we were doing too much. That a lot of patients who were going to be getting a reduced duration didn't need monitoring to begin with. I would also say we had a lot of patients that there was no need as you were stopping to reassess a dose. And so if the process in our pharmacy is that pharmacists are doing all the vanco dosing. So if you'd see drug levels coming back, a pharmacist would stop and start redosing and not necessarily think, what's the indication? Can I stop or transition therapy to something else? So one of the big projects that is not entirely evaluated yet is when our pharmacists evaluate vanco levels, can we just stop? Maybe we didn't need the levels to begin with, but can we recommend a discontinuation? Discontinuing takes a little bit less time than continuing to monitor ongoing. So that's one of the things that's improved efficiency with vancomycin. The answer is no vancomycin or less vancomycin. Yeah. Liz, how are we on time?
We have 15 seconds left.
Oh
So
gosh.
with that, I think we'll close out the session. Thank you so much for everyone for joining us this afternoon. Thank you so much, Dr. Susan Davis, again, for a really engaging conversation. And thanks so much to all of you for participating in the chat and sharing your discussion items with us. We really appreciate it. So take care, everyone. On to the next session, which may or may not be a break, but regardless, enjoy the rest of your day. Thanks all.
Have a good day. Thank you.